and talking and exchanging a little bit. And then you got to the end of all that information and you simply said, okay, what do you know about the pill? Or even if you said, I want to make sure I did a good job of explaining that, can you tell me what you know about the pill? That's such a broad invitation, and you've given her so much information that it's going to be really difficult um, for her to figure out well, maybe I can't, maybe I don't even know. I can't figure out where to start from that. So that's a little bit of triage, that is deciding what it is that you're going to focus on, but also being sure that your teach back question, is specific. So you could say, let's talk about missed pills. Can you tell me what you're going to do if you're away for the weekend and you miss a pill? And then that patient really has a focal point for doing teach back. So, and again, triage, the important thing about triage is to think ahead of time. And triage is presented as a step, but it's really mostly going on in your own mind when you're thinking about what's the most important thing I want the patient to understand. What does the patient want to know? What does the patient really need to know at home? What is a mistake the patient should not and cannot make? So those are the kinds of things you might use in triage. Yeah, Carol.
Okay to ask questions on
Yes,
this one?
yes,
Okay.
please, yes.
Because I'm thinking about when we do work in the motivational interviewing
Uh-huh.
style and negotiating what those conversations
Right.
are going to be. And so, is it ever in Teach Back could I say, what's most important to you to learn about? This is the piece most important to me, and we're going to talk about both those things. Is that
Absolutely. I mean, I think that works in beautifully with Teach Back.
okay?
Yes,
So, you could use
absolutely.
it twice in one visit, right?
Right,
So, you want to know about this, I'm
right,
going to tell you. And
right.
then, okay, okay.
Absolutely, right. Even with this example, you could start with missed pills, which is what you really want to know, and then
Mm-hmm.
say to the patient, now what is it you want to talk about? And or what do you need to be clear about? Something like that.
Okay.
And if she says side effects, you might review side effects and then do a little teach back with side effects.
Okay.
Right,
Okay.
right, exactly. Thank you.
So you
Yeah,
can negotiate that agenda
absolutely.
and hit both important points for the patient and
Right,
the provider.
right, exactly. hmm
Okay.
Yeah, and wonderful if you have the time
I know.
to do that. Yeah. So another really good triage question for yourself is how much can I actually ask them to remember?
Mm-hmm.
What is actually going to stay? Um, and there's research about the inverse relationship of more information and less retention.
Okay. Okay.
So that's another thing to think about with
Mm-hmm.
teachback. So some of the other teachback questions that might fit in with motivational or triage questions, really I'll call them, that might fit in with motivational interviewing are things like, have you done this before?
Mm-hmm.
What do you know about this? What are your worries about it? What might keep you from being able to take your pill every night?
Mm-hmm.
Those kinds of things. And then you're focusing a little bit in more on what the patient needs to know, and then you can do your teach back on that.
Okay.
Yeah. So, so triage is obviously a really important one of the 5 steps. And are there any questions from the audience out there in the ether so far? I know Carol jumped right in, and it's harder to do if you're not in the room. So feel free to ask. Okay. So we also want to spend a little time reviewing those take responsibility lines, because I found in doing teach back that that's one that gets forgotten really easily. It just seems to slip out of your mind. Your way of communicating is probably somewhat habitual, and it takes some time to reverse that habit. So this is one of the ones that you can forget. So here are on the screen are some examples of teach back. I want to make sure that I did a good job because it's complicated and it can be really confusing. Or this one I think is really good. That was a lot of information that I gave you, and it's kind of hard to remember all that information. I want to know if I did a good job of explaining it. So, as I said the last time, it's really important to figure out what is comfortable for you to say in this instance and figure out something, memorize it, say it in front of the mirror, etc., so that you're actually actively working to break that old habit of saying, do you have any questions? Or just forgetting to say it at all.
So the purpose of taking responsibility is not necessarily, or it's really to kind of let the patient's guard down so they don't feel like they're being judged on what they say or like they're being quizzed. Rather, you're just trying to make sure that they understand the information and that you're going to make sure that they do.
Right, right. And well, also that they understand and that that you really do want to do a good job of explaining to them and you really want them to have the information. So getting it right is really important for us. But if we said to the patient, I want to make sure you got it right, then that's really a test. That's really a test question. And right comes from me and wrong comes from you. So taking responsibility is also a way of shifting the responsibility it is for the communication. So. Okay, so let's do a little observation. Brandon and I are going to provide for you a little scenario here. Some of you have, I think one of the handouts that you got was an observation tool that looks like this. Okay, it has the 5 T's on it, and it has chunk and check, plain language, and stories and examples on it. So as Brandon and I are working through our communication here, you can listen and watch us and be prepared to comment when we're done and see if we're actually accomplishing this teach-back interaction as hoped for. Okay, so we're probably going to do a couple of different takes on this version. So, okay, Brandon, you ready?
Yes.
Okay. Anybody out there have any questions? Okay. So Brandon is the parent of a 9-year-old child, okay, and this little conversation is taking place after a diagnosis of asthma has already been given, and we've already had some conversation about it, and it's been discussed. And I am going to be the provider for this interaction, and so we're kind of wrapping up the conversation at this point. So just be ready to listen for those 5 T's and anything else you hear. So now I'm in my provider role. Okay, Brandon. So now that we know that asthma is what your son has, let's talk about what we can do about asthma and what medications we have that could help your son. Okay? We want him to be able to feel a little bit better, and we want to help him control his asthma. And we have 2 kinds of medications that are going to do that, along with controlling some of the triggers that set him off. Okay, so you can use these medications for chronic symptoms and when he has acute episodes. Okay, so you'll use one daily, and that will help control the inflammation that occurs in the bronchi. And this one you will use right here. This one you'll use when he's having an acute episode, and it will help when the muscles of the bronchi tighten up and reduce the flow of air to the lungs. Okay, so you've got these 2 medications to help Johnny with his asthma, and we'll make an appointment in a couple of weeks to see how he's doing with these meds, okay?
Okay.
What questions do you have for me?
I don't think that I can think of anything right now. I'll probably have some when we come back for the next appointment, but right now I can't think of anything.
Okay, all right, thank you, and we'll look forward to seeing you and Johnny back.
Thank you.
In a couple of weeks.
Because you will be back and you won't be taking your medicine, right?
Okay, let's hear some observations. What did we observe?
That you had a lot of information.
Yeah.
And you gave it very quickly because I'm sure you've got a 15-minute window
Yes,
there.
I do. I have only 15 minutes, right.
And I don't know if you triaged because you did a lot of information.
Yes, yeah.
Didn't hear you take responsibility.
Yeah.
And I think you were motivated to make sure Brandon, as the dad, had what he needed, but not in any organized, meaningful, is the patient understanding me way, was my observation.
Yeah, I didn't see any tools being used to help Brandon understand.
Right.
And then also you didn't ask Brandon to explain to you what you had just explained to him.
You know, I might challenge you on the tool thing because she did kind of show me.
I had my medicine
Yeah,
bottle
you had
here.
your medicine
Yes.
there. So we could call that. We could.
Well, you could actually really easily use that as a tool. That would be a perfect tool to use if you wanted to. Yeah.
Especially showing how it would work.
Yes,
You know, like
exactly.
do one of these, or you take 2 puffs of this. Or,
Right.
Renee said that you used a bit of jargon.
Yes.
Parents
good,
may not
yes.
understand what acute means.
Exactly.
And I was going to say the same, like bronchi.
Right.
A lot of people wouldn't know what you were
Mhm.
talking about.
Yes, exactly. Yeah, acute's another one is a good one to point out.
Yeah.
Yes. So not exactly plain language. So
Yes.
No, and Dr. Ciudad said there was no tell me.
that's right.
Yes.
No, tell me. No, nothing of the sort. Yeah. So pretty not great example of teach back. So let's try that again, okay? Okay, so now that we know that asthma is what your son has, let's talk about what we can do about it, okay? Because we want to give him some medications that can help him control it and to feel a little bit better, okay?
Sounds good.
And we have 2 kinds of medications that are going to do that, and we also want to control the triggers as well. So with the medication, here's one and here's the other. You can use them for chronic symptoms and when he has an acute episode, okay? So you'll use this one daily, okay, and that will help control the inflammation that occurs in the bronchi. And this one over here you're going to use when he's having an acute episode, and it will help the muscles of the bronchi tighten and reduce the flow of air. So it'll keep those muscles from tightening so that more air can get into the lungs, okay? So now I want to make sure that I did a good job of explaining how to use the medications to you because they're really important to help them feel better. And it's all new to you, I know. It's really new, and that's a lot of information to absorb at one time. So, and if you don't know it yet, it can seem really complicated, right? So, can you tell me how you're going to use these medications?
Yes. So they'll help control the triggers, you call them, right?
Yeah. Okay. Let me just back up a little bit, okay? Because I think I got us confused by talking about the triggers. So let's just set the triggers aside for a minute, and we'll just focus on the medications right now. Is that okay with you? Okay. And then later on, we'll come back and talk about the triggers. Sound okay?
Sure.
Okay.
Yeah, that sounds good.
Okay, so there are 2 different kinds of medications, this one and this one, and they're for 2 different things.
And I can give him both medications because you said episode, like I watch an episode of a TV show every day, and chronic, that means that it's all the time, right? So if I want to, give him everything I can to help him, so, I kind of get scared, so give him.
Yeah, when you can't breathe, it's kind of really scary.
Yeah.
Well, that's not quite exactly what you need to do, but let me go over that again.
Okay.
So there are 2 ways that asthma can cause the bronchi to become smaller. And when they get smaller, you can't get as much air into your lungs, right? Okay. So one way is when the muscles tighten up around the airway and they get smaller. Okay, and the other way is when you get an inflammation in the tissues and the mucus that blocks the airway. Okay, so let me stop again, and let's just review a little bit to make sure I got it straight this time. Okay, so there are 2 different reasons why it gets harder to breathe, right? And those are...
Well, the muscles make the bronchitis or whatever you call tighter, and then the others that the mucus and something else blocks the airways.
Yeah, that's right. Yeah, bronchi is just the medical word for airways. Okay, so let's just think
Airways.
about those tubes that get the air into your lungs.
All
Okay,
right.
so the muscles can tighten up
All
and
right.
make the airways smaller. So you can see my hand. If the muscles get tighter, then there's
Less room to breathe.
less room to breathe, right? Okay. So, or the tissues can swell up, okay, and mucus can get inside the airways, and that clogs them up essentially. Right? That makes the airways smaller too. So both things could make it harder for your son to breathe, right?
Okay.
Okay. You just can't get enough air in through those smaller airways. Does that make sense?
Yeah, kind of like breathing through a straw.
Uh-huh.
Okay.
All right. Straw that gets clogged sometimes. So is there anything that you'd like me to repeat?
I think I got it. The muscles can get tighter in the airways, and that makes them smaller, or they can get stuffed up with mucus.
Right, exactly. So we have two different kinds of medicines, and one helps one problem, and the other helps the other problem.
Okay, good.
Okay, one helps to relax the tight muscles around the airway, and the other works to reduce the irritation and swelling and the mucus that blocks the airways. Those kinds of medicines that work to reduce the irritation, we call reliever medicines, and the ones that we call them reliever medicines, the ones that relieve the muscles in an attack or an episode. And controller medicines, they control the swelling and the inflammation over a long period of time. So as you see, even I get mixed up. Okay, so now let's see if we have got it all straight together. Okay, right. So what kind of medications are you going to give them, and when are you going to give them?
Well, a lot of times I just feel really bad when he's having an attack, and I really want to help him with everything I can. Can I just give him both?
Yeah, I understand that. That's really, it's really hard when he's struggling. But you're not going to help him very much when you give him both at once, okay? Because one is over the long term, and you can give that to him every day, okay? And the one you can give to him when he's having an attack, one of those sudden things that happens when his muscles are tightening up and he can't get a breath. Those you can give him when he's having those attacks. If you give him those medicines when he's not having an attack, they're not as useful.
Oh, okay.
Okay.
All right.
So, for example, let's take an example. Okay. So let's say he's been horsing around outside with the kids outdoors, and there's a lot of pollen in the air, and he comes in and he's wheezing and having a really hard time breathing. What are you going to do? Which medicine do you think you're going to give him?
So I give him the reliever medicine, right? Yep. Even if he's already had his controller meds?
Yes, exactly.
Okay.
Right. And why can you give him both?
Well, I guess the reason he's breathing hard and having a hard time is that the muscles have tightened up, and that the reliever medicines will help that. And the controller medicine is already working to keep the swelling and the mucus down.
Exactly. You got it.
Yay.
Really good. So now let's go back to the triggers.
Okay. Sounds good.
Right. Okay. End of scenario. Okay. What happened? What did you notice? And it's lovely because I wrote the script, so I get to control what's happening in the script. But what did happen that was different from the last time?
It was a constant chunk and check, I think. You were taking turns, going back and forth, explaining, having more of a conversation, as opposed to the first time when you talked the majority of the time, and then he was so overwhelmed with the information he really couldn't think of any specific questions for you.
Yeah, exactly.
Yeah. And you were able to use TeachBack with 3 different really important things that I caught. There may have been more, but it was around, do you understand the symptoms? This is what asthma is. Here's the meds. And then there was one other. Oh, you didn't get to but you had thought about triggers, but we're going to talk about that another time because it's important for you to know these things. So.
What else?
You explained explain some of the big words. Like you let him know like what bronchi actually meant.
Yeah.
So that was a good thing.
And
What else did we
interesting.
have?
Sorry.
Paulita said that you broke down the medical jargon, i.e., bronchial versus tube airway, and Hernan Ciudad said that you explained reasons for symptoms and illnesses and relation to meds.
Yep.
Yes.
Yep. So interestingly enough, and again, I wrote the script, so I know the answer to this question, but how did I, the provider, know that he was struggling with the jargon? How did I figure that out?
Probably when you asked him to
explain it,
to explain it back to you.
Right. So this is an example of a point in Teach Back where what you are learning from the patient about what he or she doesn't know is helping you adjust back when you say it back to the patient. So instead of using the word, which as a provider I never even noticed, and using the word episode and chronic and those kinds of words are really easy to use. I heard somebody the other say to a patient, drink to thirst. I thought, oh, I get it. I understand what that means. But there's no jargon involved in that. But it's not the way you would say it in a conversation. And so what your patient is teaching you back is equally as important as what you're saying to him, because then you can adjust. That's the magic of Teach Back.
If I remember correctly, it seemed like you asked me how to take the meds correctly. And what I started doing is feeding you what the what was it? I was talking about the triggers rather than how to take the meds. So kind of what the meds did rather than how to take them.
Right. Well, again, that's a cue to me, the provider, that what you're really focused on and worried about is when your son can't breathe, which makes really good sense from the parent point of view. So you are really going back to the triggers, but also going back to, I really just want to be able to help him. Can I give him every medicine? I just want to be able to get him to breathe. So that's another clue from the patient to you about what's important to the patient.
Okay.
So yeah, and those kinds of things, when you don't have a script, which you don't in everyday life, those kinds of things enter in. Even the fact that the provider got a little off track on triggers is going to happen all the time because we don't use scripts. We always are going to talk in ways that are more confused than we'd like them to be, but Teach Back is a way of repairing that confusion. It gives you a chance to back up and say, oh yeah, I didn't really want to talk about triggers right there. That just got in there somehow. And then you can come back around to it. And again, it was the patient whose focus was on the triggers that made you realize as the provider what confusion had been introduced there. You might not have known that otherwise. Any other questions or thoughts from out in the audience? Explain the reasons for symptoms and illnesses. Yes, in relation to that. So the thing is that I think the provider in this scenario thought that he did that the first time around. Explain the symptoms and so on and so forth. So that's something to keep in mind again, that Teach Back is what allows you to see where you need to go back. So let's go on, and we're going to do a little Teach Back practice. Is anybody out there in the audience working in pairs, or are you all by yourselves? Well, let me say, if you are in pairs, you can do this as a pair. If you're not, then you will be the observers at this point, okay? What I'm going to ask the people in the room to do is to divide up into pairs and maybe we should just do one like we talked about before. Yeah. So let's just do one. And this, I'm going to have us practice really quickly with a non-medical topic. Okay. So which pair, who wants to be the pair this time around? We have you guys for the second one, or you guys for the second one. So Brandon and Misty.
Sure.
Okay. So first of all, just remember back to your 5 T's. Okay, think about using those, especially using triage. Okay, and what I want you to do, Brandon, is give Misty directions for how to get to your house from here, and give her that information using your teach back skills. And the rest of us, we will observe and see how that works out.
Okay, sounds good. So, Misty, today we are going to talk about how to get to my house.
You're having dinner, right? For all of us.
Yes. So, first, I want to use this map that we have right here, and to start off with, we're going to head up the street right outside here. We're going to take the street right over here, as you can see on the map, and we're going to go to Cole, and then we're going to take Cole all the way up to north to I-25. And then we're going to get on I-25, and we're going to go north again. So we're going to go north. We're going to go north, and you're going to get off on Comanche, and you're going to take Comanche all the way up until you get to the park right after San Mateo. And there you're going to see, and I am at 1, 2, 3, 4. You can see it on the right. It's right on there, right next to the library.
Great.
Okay, so I want to make sure that I did a good job telling you. Can you tell me where or how to get to my house?
Okay, so I'm going to use this map that you gave me. So we're going to start on the street right outside, and we're going to go up to Cole, and then we're going to go east, I think, until we get to I-25. And then we're going to go on I-25. I believe you said north on I-25 until we get to Comanche. You said go up Comanche, but I think you meant east on Comanche. So we're going to go right east on Comanche, all the way up to San Mateo. And you are on 1, 2, 3, 4 Comanche, I believe.
Yes, that is correct.
Across
That's
from
what
the
you
library.
said. Yes, across from the library.
Okay.
Actually, I said next to the
Next
library.
to the library. Okay.
Okay. Well, thank you. That is the directions to get to my house. Thank you.
Okay. I think I understand.
Okay.
Okay.
I appreciate you correcting, because I think I said north twice, but you knew that I meant east because we can't go
Right.
north
And because I'm familiar with the city. If I wasn't, I think I would have been like, I'm not sure where.
And it's interesting because Dr. Ciudad said left, right is simpler than north and south. And when you think about it, it really is, huh?
Yes.
Yeah.
Mm-hmm.
So that's true unless, like me, you happen to be left-right challenged, which means that I really have trouble. I have to stop and think about left-right. But you're right, Dr. Ciudad. You could think about, and that might be a triage question for directions, is do you know,
what are you more comfortable
Are you
with?
comfortable with north-south or left-right? What's another triage question or thought that you might have had? Misty brought it up. You're familiar with Albuquerque,
Right.
So you might say to the person, and how long have you been in Albuquerque? Do you know that the mountains are in the east and the three volcanoes are in the west and the famous mountains are in the north? Because then you can use those for orienting. So you might have done a little bit of triage beforehand with Misty to kind of get where she's situated in the city.
Yeah, now that I'm thinking about it, if she's brand new to the city, she might not know what I-25 is, or she might not know what the library is exactly.
Right. So let's see, what else did
Dr. Ciudad said, and also describe appearance of the building.
Right, exactly. So visual cues and directions are really good. So you use the library, and you mentioned a park and things like that. How about a tool?
The map.
Okay. Now here's an interesting thing, Brandon. You had a pencil in your hand. On the other side was a blank sheet of paper. And so you could actually draw a map if you're giving directions face to face with people. And the same is true of tools in the exam room or wherever the teach back conversation is happening. Sometimes this is your best tool friend is actually drawing the map. So. And what else about the other tests? Go ahead, Miss.
I was just going to say, we had taken my father and he was having surgery on his colon, and the surgeon was trying to explain to him, like, this is what your colon looks like. And both my parents were like, so he literally got a blank piece of paper and drew out like what it looked like where the surgery would be had. And they were like, oh, and they actually took that piece of paper, as something that they could take home to help them better understand. And after he drew that, after she drew that, both my parents were like, oh, now I understand where it is.
Right, exactly. And you don't really have to be a good drawer.
Yeah.
Right.
You really don't have to be an artist.
There's something about the process of working on that, physically, drawing it out and labeling things that really gets the patient's understanding quickly.
So that's good. Let's move on to a medical scenario. And we have volunteers here in the room. And that's Carol and Brandon again. Carol's going to be the provider this time. And we're going to work through a medical scenario using TeachBack. And again, remember that this is practice right now. So practice is practice. It's open-ended. You feel free to back up and, do things the way that you hope you would do, but we understand it's practice.
Yes. And see, and with my love of motivational interviewing, it's so okay to make mistakes and say, I got that wrong. Will you give me another chance? And I get them off base. And
and you
so
can back up.
This will fit perfect.
Right, exactly.
I certainly made a couple of mistakes. We didn't talk about the T's that I didn't cover. I think there was one.
What was that?
Let's see, I did triage. I took responsibility. I used a tool.
You did say tell me.
I did tell you. And I guess technically we did a little bit of try again.
Right.
So, so I guess, I think the try again was a little weak, but I guess that,
I think she could get it.
Yeah.
Okay, so the rest of us are going to be observers, okay? And if you have your tool, it helps you to kind of keep track of what you're wanting to listen for.
Okay.
Take it away.
So, I'm doing this with Brandon, so I'm going to talk across you. So I want to tell you thank you for bringing your daughter in for this visit today. And we're talking about, the immunizations and why we do the shots we do. And I really want to talk to you about the HPV vaccine, the human papillomavirus vaccine. And it might be awkward and uncomfortable. And along the way, if you have questions, stop me as we talk about this. But I think there's two important things. One is why we do the vaccine, and two, what can happen with HPV. I'm sorry, I lost my train of thought.
No, that's okay.
So both those things I need to share with you. Is there something, which one would you like to talk about first? Or do you know already about HPV? Have you heard that out in, they do television ads and stuff now, so maybe tell me what you know about HPV.
I guess not a ton. Nothing's coming to mind.
Fair
Can
enough.
you tell me?
Yes. So it's a virus, and it's sexually transmitted. So it's
Okay.
considered a sexually transmitted infection. And there are lots of symptoms to it, but some of it can be asymptomatic and not really cause problems, so you wouldn't know that you had HPV. But for kids and grown-ups that are sexually active, there can be complications from it. It's related to genital warts. People can get in their mouths and throats and around their private areas, and it could be problematic. They've also realized that this virus is linked to cancers that adults get later in life. So that's kind of the gist of HPV.
So why do I need to get a vaccine, or what does my daughter need to get a vaccine for right now?
Okay, well, that's a great question. So thank you for asking, because here I am giving you all this information about all the scary parts of it. But let me talk about the protection piece. We, as the medical community, like to give the vaccinations before our children become sexually active, because that's the best way to get the most protection. So while your daughter's not sexually active now, this protects her in the future, because the warts are nasty and the cancer can be nasty, and so I'm stuck.
So we were talking about two different pieces, right?
Yes,
And
we were
then
talking
I
about
think that I derailed it with my random question.
No, because I think that's what happens in a clinical
Yes,
setting.
yeah.
So I need to be able to follow you, but also make
Uh-huh.
sure that you're understanding what I'm giving back to you.
Yes.
So tell me why I think it's a good idea, or tell me what I shared with you that would be a good idea to get the vaccine for your daughter, the protection maybe piece.
Well, I know that it's linked to cancer now, and I certainly don't want my daughter getting cancer. And there's all kinds of weird and unpleasant side effects that go along with it, so I don't really want her to get those either. So I think that if now is the time that you think that we should do that, then that would probably be good.
Okay.
Okay. Is there anything else that you
Well, so
wanted
I
to
think
say?
you've got a sense of the concern and why we would want to immunize your daughter. And so I guess the next step for me would be to explain how we do that.
Okay.
And for this immunization, will come in 3 stages. We'll have to do 3 different vaccinations to get the full protection. And so you get one and you wait 1 to 3 months, and then you get the other and wait 1 to 3 months. And then your daughter's fully protected throughout her adult life. Do you have any questions? Or I want to make sure you understand what I'm saying about that. So
I think I understand. So it's coming in 3 stages, and they're all going to come separately. But eventually, my daughter will be fully protected. So
yes. Yes.
Good.
sounds good.
Good.
Thank
Good.
you.
Thank you both so
Very
much.
good job.
Yeah, great.
Uh-huh.
Great.
And it's awkward talking about something I'm really not an expert in.
Exactly.
You
Well,
did great. You did.
I'm not an expert in asthma.
In asthma,
either.
right?
Yeah.
Okay, fair enough.
Yes.
Okay.
Yeah, so it is easier if you're talking about your area of expertise, and you will find it much easier to, take that on as a role. If you're talking about what you know about.
Right.
That's partly why we do directions first, because usually you know how to get to your house. Usually. So what observations from you, Carol, first? We'll start with you.
Well, I know as much as I do love MI and try to incorporate that in any clinical practice, I know that it's hard to get away from, I'm an expert about certain things, so I just want to give you this information and take this and make a really good decision because I've given you everything you need to know. And so it's hard sometimes to kind of slow yourself down and make sure that I'm meeting his needs as the parent of that girl.
Right.
And, any fear, like when you think you're going to vaccinate someone for sexual activity, right? As a parent, you're like, no, my daughter's never going to have sex and that kind of stuff.
Right.
And how to, make room for that, but still keep explaining that it's important and it's really not going to make your daughter go have sex. But when sex happens, she has a layer of protection. Yes.
Exactly. Well, that's one thing I noticed that I thought you did really well was to kind of normalize by acknowledging the discomfort around the topic right away. So right away you're saying, I know this might be uncomfortable for you, but we need to talk about it. So I think acknowledging it and normalizing that discomfort is a really good way to make people comfortable. So that was good. Yeah.
And I'm open to it.
Okay.
I think another thing that I think you already started to highlight it, but you kind of started prescribing, saying, you should do this, and then you kind of walked it back a little bit, and you reframed it, and that was good.
I did try to triage between here's what it is and here's why you immunize, but those kept blending. I kept wanting to just talk about it all in one. So I don't think I did as good a job with the chunk and check maybe as I could have with practice.
Yeah. I think that's a really hard thing, and the scary thing about thinking that you're going to do teach back is that you have to do it all in one big chunk, whereas you can, in fact, in your triage process, you can say, I thought you broke it up nicely. What it is, why I do it, and how we do it. So if you're triaging it in advance, if you have the wherewithal to do that, you can say, okay, I'm going to do what it is and then do teach back. And then I'm going to do why I do it and then do teach back. And then, but basically that's where you got to. So I think that you really did do that. And like you say, it's not, you didn't have a script. You didn't have the advantage of a script. So, and you don't.
Right.
With real patients in the exam room. And so tangents happen.
We've got a nice question coming in from Dr. Ciudad. He says, how would you approach if the parent has heard bad things about the vaccine? And I think that kind of plays into what you were just talking about.
Right. So you would end up perhaps following that with the patient and not going to where you want to go right away, which is to where, here's what it does and how it protects you. So if a patient introduces a topic, you might have to go there. You might have to go there with that topic.
And I think I was trying to get to that a little bit when I said, what do you know about this? Because there is that misinformation or fear around vaccinations in general. And I think maybe Dr. Ciudad, I would have, if he brought up these negative concerns, I would say, well, let me tell you what I know. And then what else? Does that help you? I would ask those follow-up questions. Does that relieve some of your concern? And if you want, I could share these pieces of paper about the safety of, and maybe go that direction and hold off of some of the things that I wanted to cover so that I could really meet that fear of the parents.
Yeah. That's a really nice way to do it. And, that's something we could call agenda setting. So you can say to the patient, that's a really good question. I've heard other parents worried about how bad the vaccine is. Let me tell you this, and then we'll come back around to that. So that's another option you could do. Or you could face that one first. That's where the patient's mind is. So he may be able to move more quickly to hearing about it if he gets that off of his chest.
Yes.
So a couple things I noticed. We're down to 8 minutes. Is that where we are?
Yeah. So
a couple things that I've noticed. I noticed what you were doing. It was the thing that happens to everybody, myself included, which is that the impulse is to say, do you have any questions?
Yes.
Right?
Yes.
It happens.
And I caught myself at one point going,
Right. So, and it's not like you can't say that, of course. And sometimes that's productive and fruitful. So I don't want to exclude it entirely from your arsenal of things you can say. But it is, and then you went back and did the teach back. So that's one thing I noticed. And just know that that's going to happen. It's going to happen to you. And then the other thing is, and I've talked to other providers about it, and this leads me into the final webinar as well, which is that it can be really hard to find a way to say that in a way that is comfortable for you, that being the take responsibility. So, Carol, I think I wrote it down. You said, tell me what I shared with you. Okay, so that's pretty nice because, but it is also very direct.
Yes,
Tell
yes,
me what I shared with you.
yes.
Um,
I've got you.
yeah, so those, it's back to those take responsibility
Mhm.
lines where, and other providers have told me that they've tried really hard and they still end up feeling like their patient is feeling uncomfortable with that question. So I would love to have a discussion about that next time, when we all reconvene, is to think about, these 5Ts are tools for you to adapt and modify in the way that you need to make them work for you. And so, for example, coming back and discussing what that felt like for the patient. I don't know, Brendan, what did that feel like for you when she said, "Tell me what I shared"?
I didn't feel defensive
Mm-hmm.
about
Mm-hmm.
sharing back what she was sharing with me.
Right.
I felt like I wanted to, that she wanted to make sure that I understood what
Mm-hmm.
she was saying.
Mm-hmm.
That was the
Right.
vibe that I got.
Right. And so I think that you can sometimes do that, as I think you did, Carol, by being genuinely interested in making sure that the patient, if your interest is clear, that what you want to do is not tell him what to do, but figure out if he's understood, then that can really help. So that there will be various answers to that question, I think, is how do you reach that point of comfort with asking that patient to say back to you.
So here's an interesting question. When we think about patients and their just capacity for understanding and absorbing information, their literacy level, those kinds of things, do providers ever talk with you about having a different approach with different patients? Because it's interesting. I work with Brandon pretty closely. He's a really smart guy. He's got a master's degree. So I could see why I would say, tell me what I've shared with you. But then I think there's probably a mom, younger, first baby or whatever, that I would approach completely differently.
Exactly.
And do people ever talk about having those different repertoires of questions and approaches depending on
I think it's a wonderful way to talk about adapting the tool. Exactly.
Okay.
That's exactly, I since I am not a provider and I'm not seeing patients, I don't have access to those wonderful adaptations.
Right.
But I hope and encourage that you all do that. Take that out there and make it work for the way that you interact with your patients and for that particular patient that's in front of you. So,
and I think that goes also back to, like, we do a lot of cultural competence training, around diversity, and a lot of times, providers or caregivers will be like, well, I treat everybody the same, and I'm like, that's not what you should be doing. You should be tailoring your interactions differently depending on your patient, and making sure that you are taking into account what type of patient you're talking with, how they like to have conversations, things like that.
Exactly.
Okay.
In fact, I originally had 6 instead of 5 T's, and the 6th T was tailor. Tailor to your patient. So, but those questions, those triage questions that we were talking about before, have you been there before? Have you heard of diabetes? The ones you were asking him are ways of tailoring to the patient in front of you. So what we want to do now is look ahead to the final webinar, which is a couple of weeks from now. I think it's maybe down the road.
March 2nd.
Yes, so we have a little bit of time. And what I would like to encourage you all to do is to take this set of skills back into practice instead of into this world of scripts where it's much more difficult to do, and see if you can start using it. Other people have said that it's a good idea to begin slowly. Just try it with one patient every day, and with an uncomplicated topic. I was admiring Carol for jumping in on the HPV scenario because that's a really hard one. That is a hard one. So it's, if it's something you've, maybe even just flu, if you've talked with patients about flu over and over again, that might be a good place to start because you can really maybe concentrate on some of the skills that you're building And then I would really appreciate it if you could keep a log. And I think you also got those as handouts. And even if you just kept one track of one interaction and were willing to bring it back the next time so that we could talk about how it works in real life, because this is not real life. And that would be really great. That's really the meat of the next webinar is your experience. So we really rely on you to do that. And then share your experiences with your colleagues and talk about what if, I had a patient who just kept going off on tangents and I could not do teach back because I couldn't figure out what would you do if, or what can I do if. Share opening lines or the take responsibility lines. And then finally, if you have questions, bring them back for the next webinar. And here are some that I would really be interested in hearing about. What happened in real life? How did you adapt the tools? What did you find particularly useful? This one is a really important one for me. What situations or encounters are particularly suited to teach back? Because I don't think that every single interaction is. So sometimes you may just decide, no, that's not a moment for teach back. But what are the ones that are really suited to it? And since many of you
The system has detected that a minimum number of lines are connected to this conference. Do you want to continue your meeting? Press 1 to confirm. If there is no response, the conference will end.
We'll wrap up in half a second. How could Teach Back work with kids, since many of you do work with kids, and what kinds, really important, what kinds of